Hi, everybody. My name is Craig Wargon. I'm an attending podiatric surgeon at Kaiser Santa Clara. And I'm also the medical director of the Permanente Medical Group technology division called the Technology Group. And I've been very busy these last few months as I lead telemedicine and doing video visits for Northern California, Kaiser Permanente. Today I'm going to talk a little bit about some common foot conditions, both related to diabetes and foot conditions that everyone has the possibility of getting that are very common, both for diabetics and non-diabetics. So I am going to share my screen here for a second. So let me just see how I can share my screen. Here we go. This is a talk that I've given many times over the years at many Taking Control of Your Diabetes conferences. I call it Footnotes. Again, it's going over very common conditions that we see all the time in podiatry, both in diabetic patients and non-diabetic patients. The first thing I'd like to show you is, let's see if I can get my slides to advance. Oh, for some reason I'm not getting my slides to advance. There we go. So the first thing I'd like to show you is me backpacking in the Sierras a few years ago. I tend to go backpacking every year, and we live in a beautiful area, and it's great to take advantage of it. You can see I have a lot of high-tech equipment here. My backpack, my poles, my water bladder, but the most important piece of equipment that I have on these backpacking trips, when we can go literally many miles over a week at a time, is my feet. And it's really important that I keep my feet in good condition for these trips. And I say this just because you know, feet aren't the most sexy part of the human body, perhaps, but they certainly are one of the most important parts of the human body. So for diabetics and non-diabetics, it's really important to take care of your feet. And when they go out of commission, you really are impacted much more than, let's say, if you had a shoulder problem or an elbow problem. You really need your feet to be mobile, to be active. So what are we going to discuss this evening? Well, first of all, this does pertain to diabetics. I'm going to spend a little time talking about what neuropathy is. And then I'm going to talk about heel pain, which is a common problem that many adults get. And we see quite commonly, and diabetics get this as well. Kind of an icky subject, but an important one, and one that no one should be ashamed of because it's so common. We're going to talk a little bit about toenail fungus. I'll talk a little bit about bunions and hammer toes. And I'll switch back to how you should deal with routine calluses, and how to safely deal with that, and then finally diabetic foot care. So let me continue with talking a little bit about neuropathy. The word neuropathy comes from two words, neuro, which we all know is related to nerves. Opathy in Latin means disease. So what this really means is that neuropathy leads to diseased nerves that sometimes can lead to numbness, or can even lead to pain when there's no offending stimuli to cause the pain. First of all, I want to say that, you know, pain is something that nobody likes. Sometimes I refer to it as a gift, really, that nobody wants. And why do I say it's a gift? It's a gift because it's really important that our body have this really sensitive alarm system tell us when something's wrong. If we step on a needle, or if we step on a rock, or if we fracture our foot, we need to have that signal of pain to know something's wrong and deal with it. If we don't, then we could have problems with infection. We could be walking on broken bones. We could have all kinds of problems if we don't have that alarm system that I refer to as pain. So pain is, again, really something that we all need. it's a gift really, but nobody really likes it or wants it. So what's the cause of neuropathy? Well, we don't know exactly what the cause is, but we feel that it's due to the nerves being exposed to high sugar levels over time. Now, many diabetics will not get neuropathy. In fact, I would say the majority of diabetics do not get neuropathy. Part of the reason is so many people are staying in good blood sugar control these days. So that really helps prevent neuropathy. The other reason seems to be genetic. Some people seem to be more prone to neuropathy than others. So other people with even similar diabetic control, one person could get neuropathy and another person might not. And that we think is genetically related, and we don't know exactly why that is the case. And in fact, some people actually without diabetes can get neuropathy as well. And that sometimes that's referred to as idiopathic neuropathy. So the diseased nerves really results in the inability for that nerve to transmit signals to the brain. That's that alarm system I talked about. And, or sometimes it causes aberrant or false alarm signals to go to the brain, indicating that there's pain and there's something going on there when there really isn't. Or oftentimes it does lead to a decrease in sensation. The other things that can contribute to neuropathy or a disease of the nerve is smoking or alcohol abuse can also be a contributing factor to neuropathy. But the majority of neuropathy that we see is related to diabetes. So what are the symptoms of neuropathy? Well, usually it's very gradual onset. Sometimes people, like I said, have a reduced ability to feel pain and temperature. And again, we worry about that because people then will not be able to know when something's wrong with their foot or when they step on a rock or a needle or something like that. And then it can lead to significant numbness. It could also lead to tingling and burning or sharp shooting pain. And this is troublesome, especially when it happens at night or throughout the day. It can be very disconcerting for people who have this. People do have some pain when walking, but it's usually not associated with activity so much. So one of the indications or symptoms of neuropathy is when people have pain, even when they're not walking, and that's oftentimes a telltale sign or a signal to us that the pain is due to neuropathy. Sometimes the neuropathy can cause increased sensitivity, so even to light touch, people could feel tingling or very, very sensitive skin. In rare cases, it can lead to muscle weakness, and the neuropathy can travel up the leg or sometimes in the hands. And then again, in the minority of cases, most diabetics will never have to deal with this, but if neuropathy goes unchecked, it can lead to sores and ulcers and infections that are difficult to heal. And that's what we want to try to prevent you from having. Again, the majority of diabetics that I screen at these Taking Control of Diabetes seminars, when they're in person, the majority of people really don't have much decrease in sensation. So that's good to know. And so, and this does not, these kinds of things don't have to happen, and they can be prevented. The way we diagnose neuropathy is by taking a history. So if someone comes to me at night, comes to me and says, I feel tingling in my foot, especially at night, or I feel like I have a wadded up sock, just at the base of my toes, that's an indication that they may have neuropathy. We base something we call protective sensation by using something called a monofilament test. And sometimes it's called a Sims-Weinstein, of a guy who figured this out, the Sims-Weinstein monofilament test. And many of you have had this done. Basically, we use a small filament, like a fishing wire, and we place that on the skin with some pressure, as you're seeing in the picture on the slide. And when the person can feel that light touch, they are said to have protective sensation. That means that if they can feel that little fishing wire, they're likely going to feel stepping on a rock or a nail or having a fracture or sprain of their foot. If they can't feel that light touch of that fishing wire, then they have absent protective sensation. So we call that the presence or the absence of protective sensation. And we measure that by using something called a monofilament test or a Sims-Weinstein monofilament. Your podiatrist should be able to do this for you when they see you if you are a diabetic, and they should do it every time you see them, unless you see them very, very regularly. And your primary care doctor can and should do this kind of test for you as well. So how do you prevent neuropathy? Well, the mainstay of preventing neuropathy is maintaining good blood sugar. And you do that by, having a good diet, by exercise, by watching your blood sugar carefully, all the things that you hear about in TCOYD. So we basically say that, that you should be in range. This is kind of an old slide. And we used to say your blood sugar should be less than 180 2 hours after meals. But I think Dr. Edelman would say that you should probably try to be in range most of the time. Again, it's important for the health of your feet to maintain a healthy weight. So that goes along with a good diet and maintaining good blood sugar. Of course, don't smoke. Smoking can make neuropathy worse. Plenty of physical activity is good for everything, as you know. Moderate alcohol consumption, and then make sure that you do know what your protective sensation status is, and know if you have protective sensation or know if you don't have protective sensation. If you don't have protective sensation, you have to take some extra precautions to make sure that your feet don't get injured. And we'll talk a little bit about that more in a couple of minutes. The treatment for neuropathy is several medications that can reduce the abnormal sensation of pain or what we call dysesthesia. So dysesthesia means strange sensations or unpleasant sensations versus no feeling. Of course, that is anesthesia or a complete lack of sensation. The mainstay of treating neuropathy is with medication. The medication most often used is Neurontin, or the generic name is gabapentin. It's a very, very safe drug. It's been used for many years. It's actually in the class of drugs that we refer to as anti-seizure medicines, but gabapentin is not used for seizures much anymore. It's used mostly for neuropathy. Again, it's widely used, extremely safe, a very, very wide safety profile. So it's something that we often try as our first line of treatment. The other medications or class of medications that we use a lot of time for neuropathy is something called nortriptyline or tricyclic antidepressants. And some people actually use some newer antidepressants called duloxetine or Cymbalta. Now, these are not used because there's depression, but they're used because not only do they impact people who have depression, but they are used because they can affect the actual nerves that are damaged, or the neurotransmitters, as it's called. And the nortriptyline is something that's not used for depression very much anymore, but it's used in a much, much lower dose for neuropathy. It can be especially helpful for people who have neuropathy at night that wakes them up. Nortriptyline can help keep them asleep. And then again, the other medication that's commonly used for neuropathy is called Cymbalta. There are other, I forgot to mention one other anti-seizure class medication, and that is known as Lyrica or pregabalin. Again, a little bit newer medication than gabapentin. It's in the class of drugs that are the anti-seizure type, not used for seizures very much anymore, but again used for neuropathy. And you might ask, well, why are there 4 different and 2 different kind of classes of these drugs? And the reason is our biochemistry is all different from one another. And what works for one person doesn't necessarily work for another. So we usually start with one of the more safe and common ones and see if it works. And if it doesn't, then we switch it to something else. So it's a little bit of trial and error, but usually one of these 4 medications for neuropathy does help. In less common instances, when we're really having trouble, and again, I can't remember the last time I used this, we have used patches that have some local anesthetic in it. So those are called lidocaine patches. And then we rarely use opioids. It's not recommended. And, I don't have to say much more about opioids. We all know the problems with using that as a treatment for neuropathy. There are some complementary and alternative ways to treat neuropathy. One is called capsaicin cream, it's a topical cream that you can buy over the counter, and you spread it out over an area you're feeling some discomfort or some altered sensation, and it can lead to some relief. It has some of the same chemicals in it that are found in cayenne peppers. The other complementary and alternative supplement is called alpha lipoic acid. This you can buy as a supplement over the counter. 600 milligrams a day has been shown to help relieve some of the symptoms of neuropathy, and again, it's very safe. And just in passing, some of the other methods that have been used is something called TENS stimulation, or transcutaneous nerve stimulation. Acupuncture has been used in some cases successfully. And biofeedback can be very helpful. I have a friend who has neuropathy, and he uses a form of biofeedback. And basically, when he puts his mind off of his feet, and when he gets busy, or when he uses some type of other distracting type of device, he learned how to just kind of put the pain away, and that tends to go in the background. So that seems to help some people as well. Okay, I want to switch gears here and now talk about something that's very common in everyone, not just diabetics. It's called heel pain or plantar fasciitis. It's like I said, it's extremely common. You probably know people or have had heel pain yourself. A lot of times people will say they have a heel spur, and that's kind of a misnomer, because heel spurs don't cause heel pain. Heel spurs sometimes tend to occur in people, again, just for genetic reasons. We don't know why, but they don't always lead to heel pain. In fact, when we treat plantar fasciitis, we never really address the spur at all. Plantar fasciitis, as you can see here in the red area, is some inflammation or tearing of this ligament in the arch of your foot called the plantar fascia. Hence, it's called plantar fasciitis, inflammation of the insertion here of plantar fasciitis. The good news about plantar fasciitis, it's easily treated. It almost always gets better, and it doesn't lead to any permanent problems. The common signs and symptoms of plantar fasciitis are pain with first step and pain on the bottom of the heel, just in front of the heel pad or on the inside of the heel pad. When I say inside, I mean big toe side. People oftentimes are startled by this because they get up with the first step in the morning and they really feel a lot of pain. And then a few steps later, the pain tends to improve throughout the day. That tends to be repeated throughout the day when people are at rest and they stand up again, and that first step after some period of rest hurts again. If experiencing that, you definitely have heel pain. So the treatment for plantar fasciitis is quite straightforward. The first thing you should do is if you are a walker or a runner and you've increased your activity a lot because of the pandemic, and you're walking every day and never taking any rest, you want to try to start breaking things up a little bit and do some cross training. So try other forms of activity, or just take some breaks and don't walk or hike or run every day. We'll talk a little bit about shoes in a couple of minutes. Arch support is going to be very helpful. Icing and injections are the way that we treat this problem. So let me talk a little bit more about these specific types of therapy. Again, cross-training. So I always tell my patients that they shouldn't rely just on one form of exercise. Cycling, indoor cycling or a bicycle trainer, a rowing machine, swimming, are all other good forms of exercise that should be considered. Walking is fantastic, even running or hiking, fantastic. But when you do it every single day without rest, you can end up with some of these conditions, and sometimes they're known as overuse conditions. So I highly recommend breaking up your exercise routine with some other things besides running, walking, or hiking. Shoes play a huge difference in plantar fasciitis. It turns out that shoes with a little bit of a thicker and stiffer sole all across takes some stress off your feet. And when you get your heel up a little bit, it takes tension off the plantar fascia and lets those little micro tears start to heal. So a lot of times my patients have said, I've noticed when I wear a clog or Crocs, or even women who say they've worn a high heel, that they've noticed that it makes them feel better. So we like these kind of shoes with a thick and stiff sole all the way across with a little bit of elevation in the heel. It makes a huge difference. And sometimes that's all people need to do is a little bit of activity modification and changing their shoes. The next thing we do often is use over-the-counter arch supports. If you just go to CVS or Walgreens, you're probably going to buy something that's not strong enough. You need to buy an arch support that has a very firm arch and that doesn't bend very much, because that's what's actually going to hold your arch up and prevent the plantar fascia from pulling too much and your arch flattening. The ones we use most commonly are Superfeet. That's the example here. And you can see it has a really hard plastic mold or body to it. And when you actually try to bend that in half, it won't bend. And that's what you need. If you buy something at DeLong's or Walgreens, you're going to get something that bends easily in half, and that's not going to do it for you. I recommend people go to a good walking shoe store or a good running shoe store, and they will have these kind of better quality arch supports. But what you're really looking for is an arch support that you can't take with your hands and bend in half. If it's stiff and a little bit firm, then you're probably on the right track. Stretching is really important for good foot health and for heel pain. So I think we all know how to do this against the wall stretch. In this particular example, the figure here is stretching her back calf. And a couple of things that you should notice is that she's standing up real straight. She's not bent over at the waist. Her front knee is bent and her back knee is straight. So she's stretching her back calf. And the more she bends her front knee and keeping her heel on the ground, the more she's going to stretch her calf. One of the little tricks that people don't realize is that you should make sure your toes are pointed in a little bit, like you're pigeon-toed. Don't stretch with your toes turned out like you're a duck. You want to be more pigeon-toed when you're doing this stretch, and that will help stretch the calf muscle. The other thing, this towel stretch, when you first get up in the morning, if you have that severe pain in the very beginning, using this towel stretch, pulling your toes and your forefoot more towards your knee before you get out of bed and walk is a good way to prevent some tearing, and a good way to prevent tearing of that plantar fascia, and a good way to prevent that pain when you first get up in the morning. And then icing can be very helpful. We try using a reusable device or a Ziploc bag filled with 4 parts water and 1 part rubbing alcohol. It'll become a nice slushy mixture that you can put up, you can rest your foot on for 5 or 10 minutes. I just like taking an ice cube and a washcloth and rubbing it for 5 or 10 minutes on the area that hurts. That can be very helpful. Doing this 2 or 3 times a day can be very helpful. And then you want to avoid barefoot walking and avoid using very thin-soled shoes. So no barefoot walking, and definitely no fire dancing. You have to wait till your plantar fascia gets better before you go back to fire dancing. Okay, I hardly ever use anti-inflammatory medications like Aleve or ibuprofen, because it really doesn't get down to the plantar fascia and do anything. It can act as a pain reliever. So if you need those medications to just to get over the hump of the pain you're having, by all means, they're fine, as long as you don't have any reason not to take them, and you have healthy kidneys and stay hydrated. We do use cortisone injections when people are in a lot of pain and they just want something quicker than what these other methods can lead to. So we do inject the area with a mixture of cortisone and local anesthesia. The cortisone can kind of sometimes help up the speeding process, but again, it's not absolutely necessary. It's kind of your choice if you want to see your doctor and you're just really suffering with this and you want to get a cortisone injection. Usually that cortisone injections are very safe and don't have any real downside effects other than that they're not terribly comfortable to endure for about 30 or 40 seconds. They can be quite uncomfortable initially. You might have heard people doing surgery for this. We rarely do surgery. I can't remember the last time I had a patient who needed surgery. Sometimes you've heard of something called extracorporeal shock therapy. It's really more of an experimental treatment. It's very expensive, and it's something in my practice that is not needed to get people over the hump with heel pain if they pay attention to these other methods. Okay, I just wanted to show you another example of beautiful meadow in the Sierra Nevada. This is called Emigrant Wilderness. Again, this is where that I go backpacking once a summer generally. Let me just talk a little bit about a bunion. Bunions are common, more common in females than males. Mostly occurs by genetics. It's not caused by shoe gears. A lot of people think, although shoe gear can make them hurt more and make them a little bit more uncomfortable and inflamed. The bunions is not a growth, but rather a bump on the inside of the foot here next to the big toe. It's not caused by any really extra bone, but mostly the bone migrating into non-proper or malposition, as we say. So it's basically the first metatarsal bone, this bone here, which is connected to your big toe, spreads away from the other metatarsals in your foot, really pooching out on the inside of your foot, if you will, causing this bump. Excuse me, and the big toe tends to fall off the other side and impinge on the second toe. So again, mostly genetic. Most of the time, the reasons bunion hurt is because of shoe pressure. When people wear shoes that are wide enough, usually bunions don't cause that much pain. The pressure of the shoes can cause inflammation and swelling. It can cause a little, what we call bursa to form. A bursa is just a fluid-filled sac. And it can cause pressure on the second toe. The conservative treatment for bunions or non-surgical treatment is usually successful. So most people can simply deal with their bunions by changing the shoes, avoiding these high heel shoes and going to a more of a wider walking type shoe or something that provides some room for the bunion. Some people find this kind of padding useful. And I find it's really easy to find this kind of padding now using the internet. So just search bunion pads on Amazon and you can get a whole variety of bunion pads. Arch supports can be helpful sometimes. So that I just talked about arch supports for the plantar fasciitis. Similarly, arch supports can be helpful to prevent the bunion impinging on the inside of the shoe. Sometimes if the area is inflamed or if you're getting the bursa, ice can also be helpful. Surgical treatment is indicated when people have pain that can't be controlled by changing their shoes, or they have such a large deformity that they can't really find shoes that are reasonable to wear anymore. Bunion surgery does involve usually realigning the bones, and that really means cutting and breaking the bones and resetting them and putting in plates or wires or screws to hold them over. So it does take about a month to 2 months usually to initially heal, and your feet can be sore and quite uncomfortable for up to 6 months after the surgery. Although people usually get back to the normal activity after a couple of months. It does, depending on the kind of work you do, it require a couple of at least 3 to 4 weeks off of work. Oftentimes people take 6 weeks off of work if they have a very active job. And again, if you're a diabetic, it doesn't mean that you can't have bunion surgery. It just means that you have to have it be in good diabetic control, so you will heal well, and that you have good circulation and not a lot of neuropathy. Okay, here's another topic that people are very interested in. It's toenail fungus. It's so common you wouldn't believe it. Toenail fungus is caused by an organism. It's caused by a fungus, of course, a special kind of fungus called dermatophytes that live on our skin and our nails. It usually does not cause pain, but it definitely causes disfigurement of the nails. They can be yellow, they can be thick and very, very unsightly. They can also be a little bit uncomfortable sometimes if they become too thick, or sometimes they can make your nails turn in and it can lead to an ingrown nail. The causes of fungus in your nail is, well, it's caused by a fungus, so why do some people get it and others don't? There's about 2 or 3 reasons that people get fungus in their toenails. Some is just genetics, just the luck of the draw, that people don't have good immunity to the fungus, and the fungus is not well defended by the person's nail and body, and the fungus takes hold. And again, there's not much you can do about that. It is a genetic a predisposition in some people. If you have injury to the toenail, if you drop something heavy on it and your toenail's injured or it comes off and grows back, sometimes that nail loses that normal immunity to the fungus because it doesn't connect with your body anymore. You lose that connection from the nail to your body. The normal immune system can't really help or get to the nail anymore, and then the fungus takes hold. Sometimes that's called an opportunistic infection. And then the other reason that people get fungal nails is just because they might have a reduced immune system for whatever reason. Chronic diseases, even diabetes can cause it, as you know, your immune system to be somewhat depressed, and so that can sometimes lead to fungal nails. So, what can you do for onychomycosis? Well, one of the best ways to deal with fungal toenails is to just keep the nails thinned down and cut short. And you can see in this slide here, the person is using a toenail clipper that very strong, kind of looks like a wire cutter, and it's the best way to cut thick and fungal nails. Sometimes I advise people to get something called a Dremel drill, and if you're diabetic, only use this if you have good sensation and good circulation. And that you have to make sure that you don't use any mechanical device if you have circulation or sensation problems. But if you for some people, taking a little bit of a burr and grinding down the nails and making them thin can help. Or you can also have this professionally done by podiatrists, and that's probably the safest way to do it. Topical antifungals don't help a lot, and so less than 10% effective. Even the prescription topical antifungals don't help very much. There are some, kind of home remedies that people talk about. Tea tree oil, I've heard of vinegar, I've heard of Vicks vapor rub. I don't really think any of this works effectively, but people do talk about it. So there are oral medications you can use for toenail fungus. It's not used commonly for a couple of reasons. Even though it is fairly effective and fairly safe, it has a very high recurrence rate if it goes away at all. So in 1 year, I think 15% of the people will have the fungus come back. And in 2 years, 22% of the people have the fungus come back. And 30 to 40% of the people, it doesn't even work for. So it's not the best treatment. You do have to take it for 3 months, and I generally will monitor your liver while you're on it. There's rare instances where this oral medication can impact your liver, so you have to be a little bit careful about that. So it's not used very often just because it's not very effective long term. On younger patients who are really troubled by it and want to give it a try, it's certainly reasonable to do. Sometimes the best treatment to deal with onychomycosis or toenail fungus, as it's called, is to remove the toenail permanently. And this is called a permanent removal of nail or a matrixectomy. It's very effective if you have good circulation. It's a high satisfaction rate, and it is permanent, so then you get rid of that problem. And what happens is that nail just starts to look, nail bed where the fungus used to be, starts to look tough and like skin, and it's certainly for a lot of people a lot better looking than having a deformed, thick, ugly nail. So we do this commonly, and people find it very helpful. Just wanted to spend a few minutes talking about corns and calluses. Those are really layman's terms, but a corn sometimes is referred to as something that has a centered core to it. A callus sometimes is something that's more diffuse. Corns, especially ones on the bottom of the foot with a central core, can be very painful, and they can actually lead to sores and ulcers if it's in a diabetic with decreased sensation or neuropathy. These are relatively easy to deal with. First of all, shoes make a big difference. Once again, coming back to that same kind of strategy where we use a shoe with a thicker and stiffer sole. This is a rather severe example of it, but you can see that this shoe will help disperse loads on the bottom of the foot, disperse your pressure, and it will help reduce some of the pinpoint pressure that a shoe like this might cause a callus. So shoes play a big role. We like shoes with thick and stiff sole. This is called an MBT. A really common shoe these days is called a Hoka, H-O-K-A. You can pad the callus and try to take pressure off of it. So this is padding that builds up all around the callus. Try not to use pads with acids in them or corn removers. The corn removers are just basically acids. It's hard to control how much that acid eats into the skin, and that's not something that we really recommend, especially for diabetics. I recommend this all the time. This is an over-the-counter cream or lotion called amlactin. It has a small, very safe amount of lactic acid in it. You put it on at night, cover the callus with a Band-Aid or some type of other occlusive material. In the morning after you bathe, take your callus file, again, making sure you have good circulation and good sensation. Take the callus file and scrape down that callus gently, and then repeat this process again the next night, and do this several nights in a row until you get that callus down. That's one of the most effective ways of reducing a callus, and it's simple and easy and safe, and as long as you have good circulation and sensation. Okay. So getting near the end of this talk, especially if you're diabetic, and especially if you know that you may have a little bit of neuropathy, make sure you examine your feet every day. Have your doctor examine your feet during every visit, and all you have to do to have that happen is when you're in with your primary care doctor, just take your shoes off, and then even if they don't ask you, and have them look at your feet and say, could you check my pulses? Could you check my sensation? If you know you have neuropathy, check your shoes before you put them on. Don't use home remedies, especially like those callus removers with acid. Don't take a knife or a sharp instrument or scissors and try to cut your calluses away, or do any bathroom surgery or cut an ingrown toenail away. Leave that to the professional. If you do have neuropathy, absolutely no barefoot walking, even at home. And the most important thing is get early treatment for any problem, because just like a little campfire, before it gets out of control, you can deal with it easily. If it grows into a big wildfire, we all know what that can lead to. So we always can deal with problems much early on, rather than letting it get out of hand. And, never hesitate to call your professional for advice if you have any concerns. In our system and in many systems, you can easily take a photo and send it to your doctor and get advice that way. So that's what we recommend to our patients all the time. We bring them in very liberally if we're concerned about anything at all. And that's what you should do as well. Okay, so just to recap what I've talked about, nerves or diabetic neuropathy is caused by nerves that are diseased or damaged. They can be damaged by high blood sugar levels, or they can sometimes have a genetic component. Most of the time, this is preventable with good glucose control, and most of the diabetics that I see who come to TCOYD do not have neuropathy, and they're maintaining good control of their blood sugar. Daily foot care also prevents complications, so don't let blisters or sores get out of hand. Seek early treatment if anything like that happens. There are several classes of medications that can help for neuropathy, and there are some alternative treatments like capsaicin or alpha lipoic acid that can also help. A little bit of review of some of the common problems. Heel pain is very common, easily treated with stretching, icing, activity modification, and shoe gear modifications, and always gets better and never causes any permanent damage. Bunions are also common, genetic in nature, more common in women. Most people can live with bunions for many years, if not their whole life, without any problems. Again, non-surgical treatment is recommended as the first line of therapy. Shoes and arch supports, padding, anti-inflammatories are all mainstays of non-surgical treatment, especially shoes with plenty of room. Surgery is indicated when you have pain that you can't deal with in any other way, and it's impacting your life or limiting your activities. Toenail fungus is really common. No one should be ashamed of it. It gets more common as we get older. It's usually due to an injury or genetic factors. The fungus invades the nail and it's really hard to cure. Just keeping the nail filed down or burred down can be the best way to treat it, and keeping the nail relatively short. If the nail is really thick and deformed and uncomfortable, permanent removal would be a good option. There are oral therapies, but they have their drawbacks, especially a high recurrence rate after a year or two. So, whoops, this is from a previous lecture. That should do it for my lecture. Thank you very much. And I hope you all stay safe and healthy.